Welcome to the ASCO e-learning weekly podcast, a weekly educational series focused on helping learners identify knowledge gaps and stay up to date with the latest in new drug developments, cancer treatments, and patient care approaches. This episode is complementary to an education session presented at the 2019 annual meeting. For more detailed information about the education session, make sure to check the episode description for links to ASCO's meeting library.
Hello, my name is Karen Autio. I'm an assistant attending in medical oncology at Memorial Sloan Kettering Cancer Center. I work on the genitourinary oncology service as well as in our Phase 1 immunotherapy clinic as part of our early drug development group. Today's topic relates to immunotherapy options beyond anti-PD-1, anti-PD-L1. We will discuss one patient's evolving story on immunotherapy clinical trials. Deborah is a 54-year-old woman who was originally diagnosed with stage 3B squamous cell cervical cancer. She was treated with chemotherapy and radiation. However, within 4 months of completion, she developed liver metastases. She was offered a standard chemotherapy option with cisplatin, Taxol, and bevacizumab, or consideration in a clinical trial. She has a good performance status, no history of autoimmune diseases, and is interested in immunotherapy options. The clinical trial she is eligible for is using a combination of a CTLA-4 inhibitor with an anti-PD-1 antibody given for 4 cycles, followed by single-agent anti-PD-1. As you can see, this patient has more than one treatment option, but they take different approaches. How would you counsel the patient in this decision? The standard treatment for women with metastatic or recurrent cervical cancer that cannot be treated with radiation or resection is chemotherapy plus bevacizumab. The goals of therapy are to delay metastatic spread and prolong life. At present, there are no FDA-approved immunotherapy agents for metastatic or recurrent cervical cancer. The clinical trial would represent an investigational option and a reasonable one to consider for a patient with a good performance status. Most patients considering a clinical trial will want to know about preliminary efficacy, and for a Phase 1 trial, it's obviously important to emphasize the primary goal is safety and dose finding. Anti-PD-1 therapy in cervical cancer is being explored. The KEYNOTE-028 trial evaluated pembrolizumab, an anti-PD-1 antibody, and found an overall response rate of 17% in PD-L1 positive metastatic refractory cervical cancer. While single-agent anti-PD-1 therapy is now approved for multiple tumor types, there's a strong need to improve response rates. Dual checkpoint inhibitor therapy has been and continues to be explored. The most common checkpoint inhibitor combinations use anti-PD-1 with anti-CTLA-4 agents such as ipilimumab and tremelimumab. However, there are numerous other checkpoint molecules under investigation. Checkpoint molecules can be categorized as blocking inhibitory molecules or agonists of stimulatory checkpoint pathways. To name a few in clinical development include inhibitory antibodies targeting LAG3 or lymphocyte activation gene 3 and TIM3 or T-cell immunoglobulin and mucin domain containing protein 3. Other checkpoint strategies include molecules that act as agonists and directly stimulate T cells. GITR, or glucocorticoid-induced tumor necrosis factor receptor-related gene, CD40, and OX40 are all examples of such agonist compounds. ASCO 2019 highlighted several of these agents. For combined checkpoint inhibitor strategies that are FDA approved, ipilimumab and nivolumab as combination therapy are approved in 3 indications: metastatic or locally advanced melanoma, intermediate poor risk renal cell carcinoma, and mismatch repair deficient colorectal cancer. The overall response rates across these tumor types was statistically improved relative to single-agent anti-PD-1 antibody therapy. In melanoma, the overall response rate was 57.6%, and the ipilimumab 3 mg/kg plus nivolumab 1 mg/kg treated arm compared to 43.7% in the nivolumab 3 mg/kg alone arm and 19% in the ipilimumab 3 mg/kg arm. Checkpoint 214 is a randomized controlled trial of intermediate and poor risk renal cell carcinoma using 1 mg/kg of ipilimumab and 3 mg/kg of nivolumab for 4 cycles, followed by nivolumab versus oral standard of care sunitinib. The objective response rate was 42% for the ipi-nivo combination and 27% for sunitinib. Treatment-related adverse events leading to drug discontinuation occurred in 22%, versus 12% of patients respectively in this trial. In MSI-high colorectal cancer that has progressed following 5-FU oxaliplatinum and irinotecan, the same combination of ipi/nivo was granted breakthrough approval based on the CheckMate 216 trial with an overall response rate of 46%. Response rates for dual checkpoint inhibitor are higher for these tumor types, however, are also notably associated with increased toxicity. In phase 3 trials with melanoma, 55% of patients experienced a grade 3 immune-related adverse event. Because of this, patients must be educated on expected toxicities and counseled on the need to report symptoms early. Let's go back to our case. Deborah enrolls on the clinical trial and completes 4 cycles of combination therapy. She tolerates therapy well overall. She develops hypothyroidism, for which she takes thyroid replacement therapy, and xerostomia, which is treated supportively. Her first restaging scans indicate a partial response, and with time her response deepens. She continues on single-agent anti-PD-1 for another 18 months. She then has a scan which suggests small progression in 2 liver metastases, with the remainder of her disease stable. She is asymptomatic. A follow-up scan confirms progression in these 2 lesions. What do you do next? She now has confirmed progression on scans, although the majority of her disease is largely stable. Several approaches can be considered. One could continue the current therapy as progression is small and you feel she is largely benefiting. Another option allowed by the trial is reinduction with the combination of ipi/nivo. Alternatively, she could discontinue the trial therapy and use a standard of care chemotherapy or consider another trial. The patient is reinduced with the combination for 4 cycles on the clinical trial, although this strategy is investigational. Interestingly, one of her 2 tumors begins to shrink. The second liver metastasis, however, does not, and continues to grow on subsequent scans. You biopsy this metastasis, and the biopsy confirms active tumor. Given the growth in this lesion, what would you do next? There is not a clear-cut decision as to what is the best approach, but you recognize that she seems to have an escape lesion, which is a metastasis that seems to be growing or has developed an alternative pathway of growth or resistance mechanism, while the remainder of her disease has been quiescent. Escape lesions while on immunotherapy have been reported in multiple cancer types, including melanoma. These may be treated with focal approaches such as surgical resection, cryoablation, or radiofrequency ablation. The optimal approach for cases of escape lesions is uncertain, but is an area of investigation. In a retrospective study, Bello and colleagues reported at the Society of Surgical Oncology in 2018 a series of melanoma patients who underwent surgery for resection of residual disease following prior checkpoint inhibition therapy. In this series, there was a subpopulation, about 100 patients, who had a single escaped lesion. 60% of these patients were alive at 5 years after resection of their escape lesion. Further prospective evaluation is clearly necessary, but compelling for this strategy of local tumor control. You refer her to interventional radiology for ablation after sponsor approval. She undergoes successful ablation and is maintained on anti-PD-1 therapy for another 4 months. At that time, she develops progression in several lymph nodes with 2 new liver lesions. At this juncture, you think she is no longer clinically benefiting from the trial, and you investigate other trials and discuss standard of care chemotherapy options. She is not interested in chemotherapy. One of her clinical trial options is investigating a vaccine-based therapy using a prime and boost strategy. Vaccine therapies are just one other general category of immunotherapy. HPV is a common DNA virus that infects genital surfaces and is associated with serotypes that express oncoproteins that inactivate tumor suppressors like P53 and RB. HPV is a known causative agent in cervical cancer. Other cancers, such as head and neck cancers, vulvar, penile, anal, and vaginal cancers, can be caused by the HPV E6-E7 serotype. The E6 and E7 are foreign viral antigens, and unlike most autologous tumor-associated antigens, are more naturally immunogenic. This makes them appealing for vaccine therapies. In the clinical trial that Deborah is a candidate for, an adenovirus vaccine has been modified so that the immune system can react against the E6-E7 proteins. thereby priming the immune system. This is followed by an oncolytic virus that can penetrate, reproduce, and kill the tumor cell. This may be considered a boost effect. After careful discussion with our patient, she elects to sign consent to this new protocol. She has previously derived benefit from dual checkpoint inhibitor therapy, and this represents another opportunity to engage her immune system using a different mechanism. Thank you for listening to this week's episode of the ASCO eLearning Weekly Podcast. For more information on immunotherapies beyond anti-PD-1, anti-PD-L1, visit the Comprehensive eLearning Center at elearning.asco.org. Thank you.
Thank you for listening to this week's episode of the ASCO eLearning Weekly Podcast. To make us part of your weekly routine, click subscribe. Let us know what you think by leaving a review. For more information, visit the Comprehensive eLearning Center at elearning.asco.org. The purpose of this podcast is to educate and inform. This is not a substitute for medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.